delighted to be here to talk about my experience in EXAPA in Paris, in a treatment and prevention center. I would like to thank Gilead for the invitation. In terms of disclosure, I'm not being paid for that presentation. So I'm going to talk about my experience in EXAPA, what it changed in our practice, screening hepatitis C, and how we manage patients now that we have this comprehensive approach. Now, before we start, maybe some background information about what are XAPAs. Not all of you work in such centers, and even when we work in such a center, we're not very savvy as to how they are coordinated. In France, we have short of 500 such XAPAs on the whole territory, inpatient setting or outpatient setting. Most of the time, they are operated by associations or by hospitals. And in those centers, you are being treated free of charge with some possibility to receive anonymous treatment. The number of patients treated in those XAPA and answering the different yearly surveys, we're discussing 308,000 people. So that was as of 2016. In my next slides, I will present the population, but we have on average 700 people by center. And of course, we have an over-representation of persons with severe addictions and severe psychiatric comorbidities. Obviously, people who have a hard time managing those behavioral issues either see the GPs or see first-line medical doctors. But when they are faced with more issues, especially because of comorbidities, then they are addressed to XAPAs. So the XAPA I'm going to talk about is in Paris. We have about 2,000 people being taken care of. When it comes to the profiles that are treated in that center, it's pretty close to the type of profiles that we find in the rest of the territory. We probably have a little less people with alcohol addiction. We have a little less cannabis addictions, more cocaine, which is maybe more specific to the Parisian region. Now, in the past, our populations were slightly different, and this has changed. It seems that the number of people injecting drugs is on the decline, and this is good because this is a vector of infection by HIV, HBC, and HBV. Now, when it comes to HBC screening, there have been 23,000 screening performed. When you ponder that in comparison to the rest of the population, that's about 44%. Now, we know that it's difficult to send those population in a lab, and so they are more prone to taking those tests in XAPAs. We have a few data on VHC prevalence. We have the data from the Coquelicot survey of 2011, and the prevalence of 44% is in patients who have injected drug at least, or snorted drug at least once in their life. So we do see that we have a number of people in XAPAs with alcohol abuse situation, and so they do not fit in those criteria, and so they are underdiagnosed. VHC, we know, is a disease with a slow evolution, and we see that this disease, the prevalence is increasing, but also the number of fatalities between 2000 and 2016. About half of our patients have not been screened. In 2018, the Ministry of Health has been very vocal on their will to eliminate hepatitis C by 2025. Of the last figures that we have, about 100,000 people remain to be treated. 75,000 are not even aware of their status, so there's still a lot of work to do in this area. Now, if we have a closer look at the number of people infected with the virus in the at-risk group, we see that we have not reached the thresholds that will make it possible to eliminate the disease by 2025. Amongst those people, it's mostly drug users injecting drugs. We're discussing 43,860 people that remain to be treated if we want to eliminate the disease by 2025. Now, there are a number of guidelines and recommendations that have been published by the French Society of Hepatology, and there's a simplified pathway which makes it possible for people to access treatment, especially when there is a co-infection with HBV, HIV, or in case of alcohol abuse. And so those people can access XAPA quicker. Now, when we look at the pathway for a HVC person, we know that we have about 47,000 drug users in France. So, of course, we start with screening so that those patients are aware of their own status. So we've improved the situation, but we can still make further improvements. There should be a screening every year for injecting drug users and a screening every 6 months for the more at-risk populations. And unfortunately, we're not meeting those guidelines with blot paper, with the rapid tests. We could do that. We could reach that threshold of, we could meet those guidelines, especially when there has been an exposure to drugs. We can implement some rapid testing modalities. However, most of the time we forget to do that, and I think we can improve the situation. Eligibility to treatment, we've seen the recommendation by the Center for Hepatology. Of course, we need to assess the severity of fibrosis, and a FibroScan or blot tests can help having a proper assessment. This has been an obstacle for many years, and people became discouraged, obviously, because you have to take repeated tests before you are eligible to treatment. We have more and more access to antiviral drugs, at least in France. Of course, there are still some obstacles that we need to alleviate or remove. Now, about healing and support in compliance. Well, in XAPA, we are very much used to helping people being compliant with methadone and buprenorphine treatment. And so we do have this expertise and this experience. I'm not sure this is the biggest part of the problem. However, now on recontamination, of course, we need to have rapid tests, but we also need prevention measures for us to assess viral RNA. Some blotting paper tests are not sensitive enough to spot those RNA changes. Now, in our center, in the last years, we have implemented a number of initiatives. So this is a partnership with Gaia. Gaia is an association. They are very active in our structures. They do have a mobile FibroScan. They implement a number of rapid tests, also with blotting paper. So in our center, we work in close collaboration with them. In the past, we used to only have them intervene on 2 outpatient centers. Now they also operate in another outpatient center. So this is a center where we have less people with alcohol addiction, less drug users. However, we were surprised by all the positive tests that came out of this systematic screening. Now, very interestingly, patients do use that site to be screened. Gaia is their contact person, and some patients do not necessarily want the rest of the team to be informed of their test results. And so they do come back on a regular basis to have an assessment of how well they do in terms of treatment and healing. And so there's a clear benefit for those patients. Also for those who do not have hepatitis C, but they do want to check the improvement of their liver elasticity. We've also subscribed to those guidelines by SOS Hepatitis, an association. So this association named SOS Hepatitis has described 15 measures, and I'm not going to go into the details of each of them, but very quickly, we would like hepatitis C to be treated with interferon C, but it was a long treatment. Now, with antiviral drugs, those are more potent drugs, and so it completely changed all the somatic problems in patients. And it's a good way for them to be screened, be assessed, and be treated. So it really created a momentum, and thanks to that momentum in the XAPA, we were also supported, of course, by our institutions. So we need to have, of course, the tools, but also all the players mobilized. And so it's working pretty well. And of course, we're still trying to find avenues whereby we can improve. We used to have a specialist in addiction, Anne-Béatrice Junior. She was our consultant. She was working in close collaboration with the other outpatient treatment options that you have in La Pitié-Salpêtrière, for instance, another Parisian hospital. But it's very good that we have a specialist in hepatology on site. So it's starting from that close partnership that we've had a specialist in hepatology on site. We have people that do not want to go to the hospital, and it's definitely a plus that we have such a specialist on site. So it's really a change in philosophy, change in approach, which is definitely fruitful. We also have again a partnership with the hospital of Cauchin, and we tried to see how we could streamline that pathway with a unique ID, with a simplified access to a FibroScan and a number of outpatient options. Well, of course, you have to know that a number of people from our center do not want to go to the hospital, even if they only have to cross the street, literally, to go to that outpatient consultation. So we try to have a strategy for screening, and we'd like to have we would like to have an alert in the patient file if the patient has not shown up for screening, so that we can make sure that they come for screening as soon as possible. We also provide trainings, a number of training to rapid tests, training to FibroScan and GenExpert, in order to have this scan and treat approach. So we try to raise awareness in all the healthcare professionals. We also would like to have, as I said, this alerts in the patient file. Also, we'd like to cover the populations in jail. There are a number of things starting, but when the time in jail is very short, we know that the teams do not provide treatment and do not necessarily go through the screening phase. So there's still way for improvement and room for improvement. But generally speaking, we do see a lot of commitment from the different institutions and therefore a lot of improvement as well. Thank you very much. Thank you, Laurent. We are going to transition to the next presentation. I wasn't informed that jail was a place where you could also do this sort of screening. So we're going to listen to the experience of another center, the center from Douarnenez. I've seen in your background that in the past the structure was named SPEED, so you don't rush, you have all the time you need.
Good morning, I'm Yann Durang. I'm a nurse at the XAPA of Lorient in Morbihan. I'm very happy to share my experience and my work with you. I'm also the designated nurse for hepatitis C for the Brittany region. I'm going to explain how our XAPA participates in the elimination of hepatitis C in our structure and through a regional project by leading an experiment. This project is part of a harm reduction policy for our users. Before 2018, we wouldn't take care of hepatitis C in our center, but the whole team is now very much involved. No interest. The background. So our center is an association. It means a new land in Britain. It's a result of the merger of two associations, the CCAA and the SPID. We had the XAPA agreement in 2009. We started the TROD, the quick screening test, in 2018, and now in 2018 we have a one-stop for hepatitis. We cover the whole department. There are 4 XAPA plus 1 branch, 1 CARUD that goes through the whole department with a camper. We do harm reduction, and 50 professionals, traditional, the same for all XAPA, addictologists, nurses, educators, etc. Our XAPA today, we have 4,700 patients in the Morbihan department. We have common actions, the same actions as all XAPA. We handle all addictions with or without products. The specific characteristics is a one stop for hepatitis. We dispense e-cigarettes, and we send equipment material by mail throughout the region. XAPA without hepatitis C, we wanted to do better. The screening we did was traditional before 2018. The doctor prescribed a blood test. A few patients went to the lab, so we didn't know anything about the serology of the patients. We thought we had to do better. The hepatology consultations at the hospital, the patients didn't attend. In the hospital in Lorient is a labyrinth. You have to go through several offices before seeing the doctor. So our patients, it was really very difficult for our fragile patients. Very few attended the appointments. And it says we're supposed to look for somatic comorbidities. We also have strengths. Our team is working very hard. We had the quick screening test training in 2017. We have efficient treatment with short duration, with a few or no side effects, and we have designated hepatologists in the department. And the ARS, the Regional Health Agency, they decided to fund an experimental project for screening and managing of hepatitis in Xapa. The Brittany region also wanted to have not only the screening of hepatitis C, but also for alcoholic fibrosis, so early detection, screening of alcohol fibrosis with a FibroScan. The experiment was supposed to last 6 months. It started in 6 months. It was just extended for another 6 months in September. It's a one-stop experiment with 5 XAPAs in Brittany, the Lorient one, in where I belong, Ploermel, Quimperlé, Lannion, and Saint-Brieuc. We have equipment. We have 4 mobile FibroScans. I share one with a Quimperlé team, and they're close to us. We also have the nurses, the doctors have time. The teams were trained by the hepatologists. We were trained for liver diseases. We were trained to use a FibroScan. And we also had funding to have hepatologist consultations in our centers. This is what happened. In December 2018, we identified the professionals. Then we made connections with the partner structures. I went physically to each XAPA to present the project, that single-stop project, that one-stop project to the centers, and the teams feared it would be additional work. That they said they didn't have the right facilities. For some teams, for some nurses, it was complicated. They said it was not their role to do that. So we had many discussions, and finally it happened. We started in April, last April. The organization, how it was proposed, it was for all patients received seen at the center. All patients could have a one-stop consultation. It's handled by a nurse who is going to collect data and then propose a screening, a quick screening test, a FibroScan, and also we checked the vaccines for hepatitis B. The nurse is present at all stages if the patients want it. After the consultation, depending on the results, the nurse can have can propose prescriptions and physically go with a patient, go to the lab with a patient. At the XAPA, we cannot take blood samples, but we can go to. Going to the lab for the patients was very difficult. The patient said, "It's going to be complicated. I don't have any veins. I don't want to go. I haven't done a blood test for years." So to physically go with a patient, with a nurse that the patient knows, So it made things easier, and all patients were accompanied. After the results, they would see a doctor or an addictologist. So the nurse goes with the patient all the way to the prescription of antiviral drugs. For the most fragile patients, I go to the pharmacy to obtain the medicine. We can also provide the drugs at the XAPA on a daily basis, or weekly or monthly. I set up a tool, a very simple tool. It's a pill organizer. I started that with a patient who was schizophrenic. It was very complicated for him, so I proposed that tool. He accepted, and then I offered that to all patients. They all accepted it. It's just for 2 or 3 months, and I think it's a reassuring tool, and it improves observance. Let me insist on all these steps with the presence of the nurse. To give you an example, on a schizophrenic patient, when we see that he was positive to hepatitis C, he was a drug user, homeless, and we thought it was going to be very complicated to observe the treatment. It's a violent patient too, and we thought that he had to be treated. So it was really a challenge. So I didn't give up. We called him. We looked for him in the street when he wouldn't come. So the team really worked hard. He is now cured, and this patient, when he was cured, he was so happy. He decided to give up drugs. So I wanted to give you this example. After 6 months, these are the figures from last month. 200 patients were screened, 222 quick screening tests, 16 positive for HCV. So that's about 8% prevalence. We did the test not only on injectors, but still. Prevalence in Brittany is below 1% in the general population, but we realize that when we look for it, we find it. 180 fibroscans, 26 in excess of 10 kilopascals, 14 hepatitis C are being treated, 6 cirrhosis, 2 advanced fibrosis, use of blotting paper to go with a lab for a patient was impossible. So the blotting papers were not part of the tests of the experiment, so we decided to use them for those who really couldn't go to the lab. What is a single stop? It's really a very close relationship with the patient, because he's accompanied at all stages of from the screening to a cure. For the nurse, for me, to be part of the elimination of potentially fatal disease as a care professional, it's very important for me. And to tell with a patient, with a doctor, to tell a patient that he's cured, it's really motivating. To participate in the cure of patients too. For many of them, it's really it's great for them to be able to be screened, treated, and cured. When the patients receive the news that they are cured and they decide to take care of them, I've seen patients deciding to go see the dentist, the dermatologist, things they hadn't done for years. Within the XAPA, we're giving back some meaning to the body. It's really really very interesting for us as a care professional, and it reinforces the relationship with family doctors, with the hospitals, the other treatment centers, and pharmacies, laboratories. To conclude, or to carry on, the benefit of the cure in the project of life of the patient, opening to prescription, which is a major, which saves a lot of time. It's easier to obtain care. This experiment is going to be assessed, and it will continue. Thank you very much. Thank you, Nice, for this nice presentation. You did it. We have time to have questions. I wanted to ask you both a first question. You have adapted differently, and in the XAPA today, you adapt with the local possibilities. Today, it feels that there are two problems. It's evaluation of fibrosis, which you need a fibroscan. It takes time, so that can be a problem. And there's another concern, another issue for a simple treatment is the evaluation of comorbidities according to the recommendations. How are you able to go around it? How do you do that, handle that in your daily practice? For the evaluation of the fibrosis level, we have used Gaia, but only once every 3 months for each site. So it requires discipline to have all the appointments on that day. So it's complicated. This is why the fibroscan is accessible at the Cochin Hospital without an appointment, and we are going to have a fibroscan that we can use with all XAPAs, where it's not only to have the fibroscan, you need someone available to use it. And it's not only for hepatitis C, but to just assess the condition of the liver. For the comorbidities, we are working in one site with a psychiatrist, addictologist in the team. So besides somatic acute problems, kidney diseases, we're in touch with the hepatologists to try to solve these problems. What's more complicated, it's when you have several issues, people with alcohol problems, psychiatric problems, HIV. This is complex, and for those situations, it's interesting to have a hepatologist on site, so we can can find a solution right away. For the rest, we follow the recommendations, the guidelines, but we talk about alcohol issues. This is our core business. And for psychiatric disorders, we can work on that. For us, for comorbidities, I have a hepatologist. He is very reactive. When by mail, when we have a doubt, he can tell us. Kidney disorders and cirrhosis within our XAPA. The psychiatric comorbidities, I talked about the schizophrenic patient. It's not a contraindication, and alcohol is not either. We systematically treat all patients. For comorbidities, it's a co-infection, cirrhosis, and kidney disorders. When we have a doubt, we can call the hepatologist or we can have him see him on site. So you say this is no problem, we can adapt. We see that several XAPA in France today, where you say we cannot, some centers say we cannot do it, but you're the living proof that the structure can adapt with the local solutions. Any questions? Good morning. Thank you for these presentations. Talking about obstacles, I work in a XAPA in CARUD in Montpellier. We have a FibroScan, experts, blotting papers, the quick screening test. The obstacle, the problem we have is we have a precarious asylum seekers and they're late in obtaining their rights. When I see the lab tests, the treatment, very often the problem for these patients that we lose, often during that time, how did you go around that to work with the Social Security to try to have the patients obtain rights more rapidly? It's a big issue for us. Social problems is a real comorbidity. We don't have many asylum seekers in our XAPA or migrants. You send them to elsewhere. I don't have any example for whom they had with these problems. In my experience, no. You lose patients by the time they obtain their rights. Where do they go? If I knew where they went, I wouldn't lose them. It's like the result of the blotting paper test. We do the TROD, or we try to shorten that time between the test and the result because we know that we're going to lose the patient even if he's screened. Maybe sometimes this public, they go elsewhere. For us, it's a real issue. We have more migrants. There were a therapeutic test, and some patients could benefit from that. But we have the same issue to have the AMEs, so we cannot start a treatment. So it's still a problem for us. Thank you. I have a question. I come from Brussels. We have difficulties in mobilizing with the Syrian exchange desks because where you don't do any more screening. What do you do for screening in France in the CARUD compared to XAPA? How do you implement that? Screening at our CARUD can be done at any time. Then if the nurses, everybody is trained to do the TROD, so there are posters to say that hepatitis and HIV screening can be done at any time. So they ask spontaneously. Sometimes we talk about it, depending on the injection practice or the risk behavior. But they ask, they go through screening. The drug injectors ask to be screened every 6 months. Sometimes they even want to be screened every 2 weeks. So we are telling them that you have to wait a while. But systematically, it is proposed at the Lorient CARUD. But at the XAPA, it's only on appointment, by appointment. We are not a CARUD, but just to explain, Gaillac, who does the TRODs and who brings the FibroScan, he's a CARUD, so they have a major activity with that. Other CARUD here, Novadona and Mustafa, we work with them. They could answer, but I think, and the issue of the TROD, the quick screening tests, there may have been problems because the training can be a problem for some structures. It's not the same thing to tell a patient he's positive to HIV or HCV. So you need to have a well-organized system. To answer our friends from Belgium, we see that the syringe exchange programs, we see how complicated it is. In France, the CARUD are supposed to do screening. It's among their priorities. In other countries, it's only syringe exchange programs. That's not where you do screening. We're lucky in France that it happens. Both are done at the same place. You should be able to do screening and vaccination when you exchange a syringe. To give the result of HCV, okay, it's easy. It's more complicated to tell a patient that he's HIV positive. Yes, that's my experience too. For the carers, it's really difficult to do an HIV screening test because for hepatitis C, you can tell the patient is going to be cured, but for HIV, you're going to tell the patient is going to be treated for life. So it's a real difficulty. For the users, I was wondering, should we offer both HCV and HIV tests? In my experience, I propose HCV right away, and during the conversation, I see whether I can offer HIV. Normally it's hepatitis C and fibrosis, but depending on the profile of the patient, I may propose HIV, but I don't do it systematically. Where the authorities are saying we should think about a triple screening, HCV, HIV, at least once in your life, you're saying it's a problem for the users and for us too. Yeah. Yeah, I noticed that when you propose that to the user right away, they don't come, or they come less to the consultations. So we have still some room for improvement, both for the users and for the professionals. Any other question? Let me ask a question to both of you. There is a hepatologist convention in Marseille, so I know they're not here. We hear hepatologists, they said today a simplified treatment, so the XAPA and can handle the treatment. So some hepatologists are saying they don't need us go home to work because they're short on doctors. Can we give up hepatology consultation, or should we fight to keep that? I think we have to keep the presence of hepatologists in the XAPA. It's always important to have the doctor, the opinion of a liver specialist for alcohol and for viral hepatitis, to have the opinion of the specialists. It's always a plus. I think that their presence is desirable. The opposite often. When the prescription was opened, a hepatologist came to the XAPA. It's because the approach was so simple. Before, you need to have a screening, then ARN, then the liver test, and then the hepatologist consultation. Now you can bypass most of the steps. It's only the blood test that is the problem, to eliminate some comorbidities. So we want to settle all situations more easily. And we realized recently that with the hepatologist at the XAPA that we were able to settle. We didn't solve all situations, but situations that had been going on for a long time, we were able to find a solution by having someone on site. So they are still needed. So keep your hepatologist. Any questions? Addictologist in the Toulouse area. It's a question for you. Are there any cases of chronic hepatitis C with spontaneous cure? Yes. Yes, there is 30% spontaneous cure. But these are people that took risks, they were exposed, and they're. But if it's a chronic hepatitis C, active hepatitis C for years or more than 6 months, can there be a spontaneous cure? I had one case among my patients, and it was beyond 6 months. People, they're chronic patients. So you should publish, because as far as I know, it hasn't been described. Other questions before we conclude? I would like to thank our two speakers, the people from Gilead. You saw their XAPA where it's possible in Paris or outside. When there is a will, there is a way. Hepatitis C is a tool. It's possible to eliminate hepatitis C. We can modify, we can change our professional practice, and it's practical to have that in the XAPA, to create a link with the hospitals, and we can do it. For 20 years, we've been saying we can do it today, but we're going to make it. We're going to succeed. Thank you.